So, is the decision to undergo a vaginal delivery versus a C-section inherently biased in our healthcare system? Child, let me sip on this tea before I spill it. Ooh, this tea is hot. So let's get into it. So, as some of you may already know, and some of you may not know, there has been an ongoing controversy, and rightfully so, the disparities identified in women who are undergoing C-section delivery versus those who are undergoing vaginal delivery. So, as you guys know, we have been walking our community through all the layers in which racism has affected our healthcare system. And the decision or the mode of delivery is not exempt at all. In fact, it may be one of the most laced area of obstetrics. Now, historically, we have talked about on this platform that obstetrics and gynecology at its foundation has just layers and layers of history in which there has been racism in the field. Now, as you guys know, we have talked extensively about the historical basis in which racism has a foundation basis in the field of obstetrics and gynecology. We know that there is a history of involuntary surgery done on Black enslaved women. We know the history of unknowing research done in terms of birth control and sexually transmitted infections. We know the history of sterilization that has been done systemically towards Black and Hispanic women. So the history is very vast, unfortunately. And thankfully, we're at the point where we're really starting to take a look at some of our practices to see how our practices have inherited this heritage of racism so that we can undo these practices and provide more equitable healthcare to all women. That is our goal. So it is no surprise that there are identified ways in which the mode of delivery may, in fact, be systemically racist. And this comes up on the heels of the controversy of the VBAC. So, as many of you guys know, women who have a prior C-section, depending on the type of C-section she has or have had, she may in fact be a viable candidate for a vaginal birth after that prior C-section, as many indications for C-sections are not necessarily repeated. There are non-repeated reasons for a C-section delivery. So if someone, for example, may have severe preeclampsia and is remote from delivery, meaning the time that it would take for her to be induced and have a vaginal delivery would be too long, and she would have a significant increase in her complication rate for her and the baby to wait on that process to happen, there may be a decision to proceed with a C-section delivery. A mom may have a abnormal presentation of a baby, or a baby with a tumor, or mom with tumors that prevent the actual vaginal birth, and she may have a C-section as a result of that. There may be cases in which moms may be pregnant with multiple gestations, and so that may lead to the decision for her to have a C-section for one reason or another. And so there are reasons why women have C-sections that are not necessarily repeated. Historically, we've also considered women who have prior C-sections due to labor-related complications. So, for example, she may stall and not continue to progress during labor and may get to 5 centimeters, 6 centimeters, 3 centimeters. Questions may increase like, what's the size of that baby? Was she induced? Which we know these factors have an impact on her success of having a vaginal birth in the next pregnancy if the issue is recurrent, right? But there are many cases where moms may have had a arrest of dilation, so she did not continue in progress to fully dilated or arrest of descent. So she did not continue in the ability to push the baby out after becoming fully dilated. For one reason or another, there may be just a slight way in way the head of the baby was that may have compromised that delivery. And so it's not unusual to have a mom who's had those indications for a C-section in her prior delivery that subsequently resulted in a successful vaginal birth after C-section. And so the goal became to identify women who were more likely to have a successful vaginal birth after C-section, where you can offer them a TOLAC, which is a trial of labor after cesarean. So the goal now is, instead of the system identifying women, that there really is a collaborative discussion between patient and clinician regarding the best mode of delivery for that patient while maintaining the patient's autonomy. That is the goal. But here's what's been going on. Now, granted, there are some obstetrical outcomes that we consider to be OB nightmares, right? So if there's a uterine rupture, if there is amniotic fluid embolism, if there is a severe form of preeclampsia like HELP syndrome or eclampsia, or if you have a patient who have a shoulder dystocia, these are obstetrical nightmares by no doubt. And so no one wants these outcomes because there's such a significant high risk of complication and death rate amongst the moms and babies. So the goal is to avoid all these outcomes from happening. But are we operating in fear or in racial disparities? So let's talk about the history of cesarean section amongst the population. So historically, we know that Black and Hispanic women have had higher C-section rates, primary C-section rates. And the question is, what led to that higher C-section rate to begin with? Are there racial biases that led to the increased outcomes of higher rates of cesarean section amongst Black and Hispanic women and other minority groups? So let's talk about the numbers to begin with. So the March of Dimes, one of our favorite organizations, collected data in regards to the cesarean rate in 2021. So we know that the C-section rate amongst American women was 32.1% of live births. Very high number. In fact, the vaginal birth after cesarean section rate, or the VBAC rate, was 14.2 births out of 100 live births. So let's break down what the actual numbers look like from ethnic group to ethnic group. Now, looking at the rate of 2019 to 2021, the rate of Black women was 36.2%. Asian Pacific Islanders was 32.7%, Hispanic was 31.4%, white women at 30.8%, and American Indian or Alaskan Natives was 29%. So as you can tell, the rate of Black women in particular was even higher than the average of the United States. And one of the theories behind this was that perhaps Black and Hispanic women, for example, are more likely to have comorbid conditions, so more likely to be diabetic, more likely to be hypertensive, and more likely to have fibroid disease and other types of conditions that may increase the rate of the need for cesarean section as a primary mode of delivery. However, there was one study that showed that even amongst healthy African Americans and Hispanic women, that the rate of cesarean section was 21% and 26% more likely than white women as a primary mode of delivery, meaning their first live birth resulted in a C-section, even if they were considered to be healthy. So there is certainly some concern for the fact that not only is the rate higher, but this particular study seems to debunk the theory that this is a result of comorbidities. And really, guys, when you look at these comorbidities, they're already laced with disparities, right? So we're more likely to be higher body mass index because we're more likely to, as we discussed on one of our previous episodes, we're more likely to not have access to exercise. We're more likely to not be able to go out of our homes to exercise because of safety issues, either due to violence in the community or policing of the community. So we've talked about food deserts, or what some are now reterming as food apartheids, right? So there are disparaging data in regards to the level of stress that Black and Hispanic women endure on a regular basis, the lack of access to healthcare system in a timely manner, the lack of ability to live healthy lifestyles because of disparities resulting in that. So even if comorbidity was a reasonable explanation, you would still have to debunk all of the other factors that lead to those comorbidities in the first place, which ultimately leads you back to racism. But nonetheless, this particular study has shown that even in the healthy groups of Black and Hispanic women, that there are higher numbers of cesarean deliveries. There was also a study that showed, because remember, we're talking about a mom should be autonomous. We should be able to provide the information and the scientific information that is currently available and allow each mom to make the decision for herself. What one study has shown was 75% of Black women and 54% of Hispanic women favored having a vaginal birth after C-section. And the problem is that is compared to 43% of white women. So even though this study has shown that there is a personal preference for a vaginal birth, there is still a disparity in a mom being able to express that autonomy in her decision making. And then we must consider, well, what are some of the issues and disparities related to a C-section in the first place? So we know C-section births are definitely more complicated births, right? We know for some of the obvious reasons, it's a surgery. Let's not forget that. And with any surgery, there's going to be a higher risk of infection, higher risk of bleeding, higher risk of injury to neighboring organs. And then let's talk about the recovery. So we know that the support system for the postpartum period is different whether you are a white woman or you are an ethnic or you belong to an ethnic minority. So there is less support for Black women. And we talked about this, especially when it comes to postpartum depression and the access to mental health services. So we know that the support system, when a mom undergoes any type of delivery, has disparities amongst ethnically minority women versus white women to begin with. But then when you add on some of the other things that we talked about previously, we know that there's a disparity in pain management, right? We know that Black women or Blacks in general are more likely to be under medicated for our pain and are more likely to wait longer for treatment in emergency rooms if we have a pain-related condition. So if you take that into context, now you have a mom who has had a surgical delivery at a higher rate than the average population, and now you have provided her less resources and less pain medication to be able to be active and properly care for herself and her family. And then let's talk about the faster rate to return to work. So the economic disadvantage of minority groups has led to a quicker time to return to birth. And we know this from the data looking at breastfeeding, that some of the early discontinuation of breastfeeding is a result of the need to go back to work and the lack of support from certain employers. And so this is a very, like I said, you guys, this is a very layered issue. But let's talk about the VBAC calculator, because this is where this has all come up. And this is an important topic. Why? Because C-section is the most common procedure in the entire United States of America. The most common procedure is a cesarean delivery. So granted, we're talking about a procedure that affects thousands and thousands of moms each year. This is why this conversation is necessary. Let's get into the VBAC calculator and that hot mess. So in general, it is believed that the success rate of having a vaginal birth after a prior C-section is anywhere from 60 to 80%. Why are we so concerned about vaginal births after prior C-section? The biggest and most concerning complication is uterine rupture. And that's essentially where the scar from the prior C-section reopens. And mind you, C-section is not the only risk factor for uterine rupture, but it is the one we're going to focus on in this particular topic. Maybe on another time, we'll talk about all of the other potential risk factors that can lead to uterine rupture. So the determination as to whether or not a mom can be actually counseled on having a vaginal birth after cesarean section starts with the type of incision on her uterus. So if she has an up and down scar in the uterus, meaning it goes in the direction of an L, then that is considered to be a higher risk incision for for a vaginal birth and puts mom at what we consider an unacceptable, unreasonable risk. However, if she has a horizontal incision in the lower segment of the uterus, and that lower segment has more connective tissue and less muscle tissue, and so the power, the force of the contraction is less likely to reopen that scar. And so the relative or absolute risk of having a uterine rupture with a lower incision in the uterus is considered to be 0.5%. And out of that, 1 in every 12 infant will have a serious complication, either fetal neurological compromise or, in some rare cases, death. So we consider this to be a very serious condition. In fact, at one point, ACOG, the American College of Obstetricians and Gynecologists, made the suggestion that women who are offered vaginal birth after C-section should really only be offered in institutions in which there is the ability to deal with the adverse outcome of a uterine rupture. So making sure that a surgical team and all of the important team members of a surgical team is available. Well, in certain communities, especially in rural communities, that is not as feasible. And so if you don't have the access to that surgical team that can act immediately in the case of an emergent situation like uterine rupture, which can lead to excessive bleeding, decreased oxygenation of the baby, which is what leads to the neurological injury and death, then those hospitals will be less likely to offer a vaginal birth after C-section as an option. And in fact, we know this based on the data available. So in 1996, the rate of vaginal births after C-section was 28.3%. And after that suggestion or recommendation, we know that the rate dropped to 9.4% in 2000 by 2004. So that's a significant drop, right? And so as a result of this sudden decrease in vaginal birth after C-section rate, there became a need to really better assess, or feel that we needed a ability to better assess women who were considered to be better candidates for this particular option. And so by 2007, there became a calculator that was provided by the Maternal Fetal Medicine Units Network. And this calculator was basically assessing certain potential risk factors, or factors that were determinants of whether or not a mom would likely be a success of having a vaginal birth after C-section. And it included things like the characteristics of the cervix. So was the cervix considered to be ripened? So ripened cervix would be a cervix that is more dilated, that is more thinned out, that has changed position, the head of the baby being more engaged in the pelvis, meaning lower in the pelvis. Those were considered to be some of the factors that could be considered. But there were also factors that pertain to mom herself, in addition to her prior history. So we consider the prior history of the indication for the prior C-section. Was it related to her labor process? Was there arrest of dilation or arrest of descent? There was a question, or there are factors that includes the mom's age, the mom's height, her weight, her body mass index. Did she have prior vaginal deliveries? And it also considered her race, and considered Black women to be a risk factor for not having successful delivery. And it also considered her ethnicity. So considering Hispanic women to be less likely successful of having a vaginal birth after C-section. Again, ignoring all of the social factors that may have led to those historical numbers to begin with. And reasonably so, because you're using a calculator to evaluate a mom without taking into consideration her story. And her story of one African-American mom or one Afro-Latina is not going to be the same as another. And we definitely live in different environments, have different social factors that ultimately led to our prior C-section in the first place. So now the fact that we had a prior C-section, which was already as a result of disparities, now you're setting us up to have repeat C-sections and all the related difficulties and complications related to a cesarean birth based on factors that we cannot control. And so between the advocacy and the reevaluation based on these professional organizations, there became a decision to change the calculator. And the race factor was removed, but the factor of body mass index and a history of treated hypertension was included. So let's talk about that. Let's lean into that a little bit. So which race and which ethnicities are more likely to have hypertension and are more likely to have a higher body mass index, which is a calculation of our height to weight? We're back at it. Black and Hispanic women. So again, you may have removed the most explicit bias and removed the actual calculation included our race and our ethnicity, but you now implicitly have continued to allow this calculation to have disparities. So I will tell you guys, I've never used a calculation in my entire career. I've only used the general counseling advice of 60 to 80% success rate. And I really do talk to every mom one by one. And they're moms who make a variety of decisions based on a number of things, oftentimes social factors, her support system, her timing, the ability to schedule a C-section. There's so many things that moms will take into consideration, and that's okay, because it is important that moms are able to sustain their autonomy. So there was a study that I read in the Journal of Reproductive Sciences, and it basically in 2022 looked at whether or not the addition of race and ethnicity improved the accuracy of the calculation to begin with. And it showed that it didn't improve the accuracy of the calculation to begin with. But what it did show was that there was continued ethnic disparities and racial disparities amongst the complication rate. So that being said, there's definitely areas of need of additional support and additional efforts to really assess our current system and all of the disparities that exist in our current system of obstetrics, to make sure that every mom is receiving equitable care. And we have gone through all the ways in which our current healthcare system and our social political environment impacts women's healthcare. And it is important for us to not only identify when we recognize these disparities and recreate new societal norms, but also address those disparities. So it's not enough to say that Black and Hispanic women are more likely to be hypertensive and have higher BMIs and not fix the issues that led to those outcomes to begin with, because it is those outcomes that ultimately increase our risk factors. So we don't just need a system that identifies disparities. We need a system that is willing to address and fix these disparities as we identify them. It is important also for us to continue to be advocates, because what led to this shift was not just the professional organizations, but a lot of the grassroots advocacy that identified and noticed these disparities and led to some of these changes. So there are areas of weakness in science, and we cannot take science as an absolute. It's informative, but we also have to assess, how is this information applicable to me? Does it apply to me? Does it put me in a disadvantage because of my ethnicity and my race? How do I apply the information from this particular study? And that's what we're here to do on HBC. That is our goal, is to be able to provide you guys with the information and assess how and why it's important to us, or it leads to further disparities. And so I hope this information has been helpful. I hope you can take this information to any mom who is faced with this decision. And as I said, as the top procedure in the United States, we're talking about thousands of women. So likely, someone who is either going to face this decision or may in fact be facing this decision right now. So I advise you to go ahead and share this information with her, or however she identifies, or he identifies, or because we're included in our transgender community, these outcomes are still applicable. And there has been no study that I've looked at that looked at the transgender community specifically. So I currently do not have data on that. So I advise that we take the information that we do have and assess it in the way it should be assessed for appropriateness, and then help others and ourselves make the best decision for ourselves and our families. So once again, we thank you for joining us. This is Dr. T, the hand behind the handle of HealthyBump.club on Instagram. And here on YouTube, you know us as our full name, Healthy Bump Club. We hope this information has been helpful to you and your loved ones. And we thank you for helping us and supporting our community, either through viewership and sharing of our information, or by supporting our apparel line, which helps us to cover some of the costs related to the platform. We hope to continue to do topics just like this one, so that we're able to edify and empower you in your healthcare decisions. We thank you so much for supporting our platform, and we hope to continue to do topics that are important to you. Once again, thank you for joining us, and we'll see you in the next episode.